Good morning, good afternoon, and good evening, everyone from all around the world. So on behalf of the Educational Committee of the ACNS, I would like to welcome you to the joint ACNS, YNS, and WIN webinar today. So today, our chair is Professor Quinlan, who is the professor and chairman of the Department of Neurosurgery of the Second Affiliated Hospital in Suzhou University in Suzhou of China. So our first speakers, we have 4 speakers today. Our first speaker is Professor Sabino Lucy, who is the Associate Professor of Neurosurgery of the Department of Clinical, Surgical, Diagnostic, and Pediatric Sciences. And he's also the Vice Chairman of Neurosurgery Residency Training Program of his unit, and also the Board PhD program in Experimental Medicine of the University of Padua in Italy. His topic today is Mastering the Transylvian Corridors, Advanced Techniques for Enhanced Access. Our second speaker is Dr. Mp/Mp/, who is a neurosurgeon of the Vascular and Functional Neurosurgery Department of the National Center of Neurosurgery in Astana in Tajikistan. Her topic is hybrid approaches in in the management of giant and complex intracranial aneurysms, a case series. Our first speaker is Professor Jeff Danilov, who is the Scientific Secretary Head of the Laboratory of Biomedical Informatics and Artificial Intelligence of R&D Berdyanko Neurosurgery Center in Moscow in Russia. He will introduce our ACNS AI subcommittee today. Our fourth speaker is Professor Nobuhito Moroda, who is the Director of the Division of Pediatric Neurosurgery, Kitasato University School of Medicine in Sagamihara in Japan. His topic is a functional posterior rhizotomy for the treatment of spasticity. We have 2 discussions today. Our first discussion is Professor Yang, who is with me now. He is the Deputy Chairman of the Neurosurgery of Tianjin Medical University and also the Tianjin Medical University General Hospital in Tianjin, China. He's also the chairman of the cerebrovascular disease surgery and neurointerventional department of the Tianjin Medical University General Hospital in Tianjin, China. Our second discussion today is Professor Ariel. He worked with the developmental cancer biology of brain metastasis, and he's also the founder and CEO and partners in healthcare clinics and foundation for underserved communities in Albania. To moderate a session with me, we have Dr. Pham, Dr. Atik, and Dr. Biswas, and Dr. Julie Sam. So without further delay, shall I hand over our platform to our chair today, Professor Nan Qing. Please, Professor.
At first, let's welcome Professor Mp/Mp/, to have a short remarks. Professor Mp/Mp/.
So thanks so much for inviting me. So thank you very much for the 4 speakers. So those are very excellent topics, and we are very much expecting their talk. Let's start, I think.
Okay, thank you, Professor Kato. So let's welcome Professor Sabino Lucy to make his lecture. The topic is Mastering Transylvian Corridors, Advanced Techniques for Enhanced Access. Welcome.
Thank you. Thank you very much for this kind invitation to Professor Kato. It's an honor and a pleasure for me to be here. Can you see my screen?
Yes.
Okay,
yes.
Thank you. Actually, this is my new affiliation because a few days ago I moved to my new hospital, so I work no more in Pavia. I work now. I'm full professor and chief of the Department of Neurosurgery in Sassari, Sardinia, Italy. So all of you are welcome to come, and I will try to do my best to arrange a meeting as soon as I can. So now the topic of my lecture is Mastering Transylvian Corridors. Why I choose this topic? I choose this topic because this webinar is especially dedicated to young neurosurgeons. So I apologize at the beginning if some of you, very expert, already know lots of information, but I want to give a take-home message, especially to the young guy. I'm Italian here. You are very welcome to visit this beautiful, beautiful Vatican Museum in Rome. And if you come to Vatican Museum, you see probably the first description of the Sylvian fissure, that is the door for the Trans-Sylvian approach, that is the creation of Adam. The creation of Adam is from Michelangelo Buonarroti. Michelangelo Buonarroti, probably few people knows that Michelangelo Buonarroti was, also an anatomist. He was very beautiful anatomist, because why? Because he did lots of dissection in brain cadavers. So that's the reason why, if you put together the focal points of this beautiful paint, you can appreciate the frontal lobe, the temporal lobe, the brain, and the Sylvian fissure. And also, if you trace a line here, you can see the brainstem. And also, if you connect some focal points of the brainstem, you see the corpus callosum also. We are talking about a painter that was born in 1475. It's unbelievable. And probably 200 years later, Francisco de la Boe Silvius described for the first time from the anatomical point of view what he called the lateral fissure, that is the Sylvian fissure. But this is not totally correct, because the Sylvian fissure has not only a lateral aspect, but there's also a frontal aspect, as I will show you very soon. This is the phylogenesis of the cerebral cortex. And what I want to show you is the fact that the lateral fissure of the Sylvian fissure, that I prefer to refer as Sylvian fissure, from the developmental point of view, is a totally intratelencephalic fissure. Why? Because in evolution from fish to the neomammals, we have some folding and bending mechanism, according to which we have a progressive enlargement of the neopallium. And the Sylvian fissure that belongs to the neopallium here is a totally intratelencephalic. This is also gestational week 23, where we can see as the frontal opercula, frontoparietal opercula, and insula, as a frontoparietal, temporal opercula, and insula as a different origin from the subventricular zone, according to the fact that the frontoparietal opercula neurogenesis come from the most apical part of the periventricular zone, neurogenesis zone, and the lower part of the periventricular neurogenesis zone is the part that will lead to the formation of some of the limbic system of the cortex of the insula. And if we can see in the embryological development, we see that the lateral fissure, the Sylvian fissure, is very early appear in the embryological development of the fetus here. This is a nice job that tell us where the Sylvian fissure start to grow, and the most plasticity point, as they told, is the supramarginal gyrus, that is the posterior end of the Sylvian fissure here, and then the progressive ontogenetic development affects the frontoparietal opercle and then the Sylvian cortex here. And then the deepest part of the Sylvian fissure is what we call Sylvian cister. And the Sylvian cister is connected to the carotid cister here, and that is connected to the crurals, ambiens, and quadrigeminal system, in what Professor ୟାşalgi called the so-called transverse fissures of the brain. So it means that from the CSF point of view, the Sylvian fissure and the latter, and especially the deepest part of the Sylvian fissure, is connected with the remaining part of the brain, according to the so-called transverse fissures of the brain. For young people, you have to have clear in mind that the Trans-Sylvian approach can have three different targets. The first group of targets is the circulation, especially the anterior circulation, but also some parts of the posterior circulation, especially basilar tip, proximal part of P1, and even sometimes P2. These territories can be reached by Trans-Sylvian approach and even SCA. The second group of targets is, constituted by the frontoparietal and temporal opercula, and also the Sylvian cortex, the insular cortex and the insular region. And the third group is the anterior and middle part of the mediobasal temporal region. We have these three clear targets for the Trans-Sylvian approach. The Sylvian fissure has a lateral part, as I already told you, and here we have the classical subdivision in anterior Sylvian point, that is the meeting point between the horizontal part, superior ascending, and more posterior ramus of the Sylvian fissure. But it's not correct to refer to the Sylvian fissure as a lateral fissure. Why? Because the Sylvian fissure has an horizontal part of the Sylvian fissure. And the horizontal part of the Sylvian fissure, as we can see here, it's probably one of the most frequent opening during surgery, especially when we want to access the anterior circle. And here we have to have confidence with the brain anatomy here. And for young people, we should always try to recognize this anatomy here at the level of the, anterior Sylvian point, where we have the orbital part, the triangular part, the opercular part, and the remaining part of the precentral gyrus, subcentral gyrus, and everything, and superior temporal gyrus also. Why you have to know this anatomy? Because we have an exact point where we should all start to open the Sylvian fissure. And this point, as we can see here, is at the tip of the triangular part of the frontal operculum. Why? Because this part is more retracted, and we have an enlargement here of the subarachnoid space. So the likelihood to endanger the vessels and neurovascular structure here is lesser if we start to open the Sylvian fissure exactly at the tip of the triangular part of the frontal operculum. And as we can see here, the tip of the triangular part of the frontal operculum is very well recognized even in MRI, and it can be very well recognized even on CT scan, and now I will show you. And the tip of the triangular part is pointing toward the insular apex. So we have to think about the tip of the triangular part of the operculum, the frontal operculum, as an arrow. And this arrow is indicating us where the insular apex is, where the limen insula is just below the insular apex here, and where to start to open the Sylvian fissure. This is a critical point, As we can see here, the deepest part of the triangular part of the triangular portion of the frontal operculum is exactly pointing at the level of the insular apex here. And in this slide, we can recognize the central sulcus of the insula that is in continuation, in line with the central sulcus of the brain. We have the 3 short gyri of the insula, the posterior 2 long gyri of the insula, and we have the anatomy here. And we can see even the MCA here with the bifurcation as usual at the level of the limen insula. And here we can, it's regardless from the, the accuracy on the definition of the exam that you are dealing with, it's a matter of the anatomy. You can recognize the same structure even on CT scan of the sagittal plane. This is a CT angio. We see here the deepest part of the triangular part of the frontal operculum pointing exactly at the level of the insular apex, and just below this the limen insula, and just below this the bifurcation, this classical pattern of bifurcation of MCA. And now I will show you later some variation. When we see at the coronal slide or MRI, we can recognize 3 different parts of the Sylvian fissure. We don't need to have any reference here. Why? Because in the most anterior part, the Sylvian fissure is oblique oriented here, and this is the horizontal part of the Sylvian fissure. This is our door to enter the anterior skull base and the anterior and the Willis circle here. So we know here that we are at the level of the anterior part of the Sylvian fissure. Why? Because the Sylvian fissure on the left side of the screen is oblique. Then we move more posterior here at the level of what they call Charcot cut, is at the level of the mammillary body here in terms of coronal cut. And here the Sylvian fissure became vertical here. And this is what Professor Ārsargi and neuroanatomists call the Sylvian vallecula. The Sylvian vallecula, practically speaking, is the Sylvian cistern, and this is the most deepest part of the lateral portion of the Sylvian fissure. And when we move from anterior to posterior at the level of the tentorium here, and we see the brainstem, the Sylvian fissure became horizontal. So I don't need to know where the cut was made. I just have to take a look to the Sylvian fissure here, the orientation of the Sylvian fissure, oblique, vertical, and horizontal. And I know very well which part of the Sylvian fissure I'm going to expose here, and I need to expose the open. On the right side of the screen, we are very close to the supramarginal gyrus. It is the horizontal part. It is one of the most difficult parts to open of the Sylvian fissure. Why? Because we are very close to the superior and inferior limiting sulcus of the insula here, and the neurogenesis, the plasticity of the supramarginal gyrus is the earliest one, as I just showed you. And this is exactly the same reference that we have in cadavers here. At the level of left side of the screen, we see the claustrum here, so the very well definition between the extreme capsule, the external capsule, and the internal capsule. And then we move toward the Sylvian vallecula, and then we move posteriorly here, and we see everything. We see the thalamus here, we see the ventricle, and everything. Sometimes it can be not so easy to recognize the triangular part of the frontal opercle, but we have to do everything. Why? Because the triangular part is always in the depth pointing. It's just we just need sometimes to split a little bit the Sylvian fissure to fully recognize this triangular shape as we see in this specimen here. And the triangular part of the Sylvian fissure, as I told you, always point at the level of the insular apex of the limb insula. And here we have to do any effort to recognize also intraoperatively what are the limits in between the frontal operculum, parietal operculum, temporal operculum, and so on, and the subopercular gyria here. And also this is the correlation that we have around the Sylvian fissure and the insula here in terms of anterior, superior, and posterior limiting sulcus of the insula. Why? Because this is our door. We have to have in mind this reference point before to start surgery in this area and before to start any kind of the transsylvian approach. And another important reference point, as I already told you, is the central sulcus of the insula that is, in continuation in the central sulcus of the brain. And this is the extreme capsule. This is the claustrum with claustrocortical fibers. And then we start to see here, because we are talking about transsylvian approach, so sometimes we perform this kind of approach also to treat AVM of the insular region and cavernoma of the insular region. And we have to know the limits that are safety for us, and the limits that are safe for us are, everything is just lateral to the putamen and globus pallidus. That is the same context that we apply in insular glioma surgery here, but we have to know very well the stratification here, according, for example, for this dissection, putamen, globus pallidus, and here the superior part, the starting point of the corona radiata just above the superior limiting sulcus of the insula, and here the stratification and the difference between the external, extreme, and internal capsule here. And we have fronto-occipital fasciculum, muncinate fasciculum. We have to know this anatomy that is around the Sylvian area and the to safely perform transsylvian approach and every kind of transsylvian approach. And also, for example, we have to know the anatomy, because the anatomy is the reference point. We don't need navigation to open the Sylvian fissure and to deal with lesions that are at the level of this area. This cavernoma here, this like a popcorn appearance, we don't know where this cavernoma here. Sometimes when I ask it to my resident, where is this cavernoma? They tell, okay, it's centrum semiovale. This is not centrum semiovale. Why? Because I see very well the starting point of the superior limiting sulcus of the insula on the left side here. We see very well the frontal operculum here. So it means that this cavernoma is not at the level of the centrum semiovale. This cavernoma is exactly at the level of the superior limiting sulcus of the insula. So what I need here is a wide splitting of the Sylvian fissure until to the posterior Sylvian point of the Sylvian fissure, where supramarginal gyrus wraps around the posterior Sylvian point. I have to open just the tailored manner, tailored way, the lateral part of the Sylvian fissure to approach and to safely remove this cavernoma. And also, we have to know the vasculature, because this is the beginning. This is what we expose with the huge frontotemporal or pterygonal approach. We have, 11 branches that you have to know very well: lateral orbitofrontal, prefrontal, precentral, and central artery. And then we have anterior, posterior, and then we have angular artery. Angular artery is critical artery. Why? Because this is the recipient vessel of STA-MCA bypass in most of the cases, because one of the most easiest one to reach, and this one of the safest. And then we have the temporo-occipital artery and anterior temporal artery and everything. And this artery can be easily visualized, also on angiogram. As professor, when I was fellow, I never forget the talk of Professor de Oliveira when I was in Brazil, and he told us every time that angiography is the skeleton of the brain, and we have to know very well the relationship between the neurovascular structure and the brain parenchyma here. And we have to take a look here always to the angiogram before to start our AVM surgery, cavernoma surgery sometime, and try to do our best to recognize and to train our brain eye, as Professor Iașag is saying, to recognize every kind of artery. And this is the late phase. And now we can have a different dominance. Sometimes frontal lobe, frontal trunk of the MCA is dominant compared to the parietal trunk. And then at the level of the parieto-temporal region, we have a mixture, we have an overlapping of these two arteries. Sometimes the frontal trunk can be dominant, and sometimes the temporal trunk of the artery can be dominant. And we have to easily know this information. We have to easily achieve this information based upon digital subtraction angiography. This is another cadaveric view. And once again, we see here the relationship between the triangular part of the frontal opercle and the insular apex and the limb insula, and the classic pattern of bifurcation of MCA. And here, this is the horizontal part with the Sivian, with the deepest part of the sphenoparietal compartment, sphenoidal compartment, of the Sivian fissure here. And this is another view. This is the transition between the carotid cister and the Sivian cister, and the MCA running at the level of the sphenoidal part of the Sivian fissure. That is the deepest part of the anterior portion of the Sivian fissure. And we have to know very well the relationship also of this area at the level of the anterior perforated substance that is delimited in between the lateral and medial olfactory stria, optic nerve, optic tract, and the anterior point of the temporal pole here. And then we have once again the MCA, and then we have all this anatomy. And my advice for young guys is to go to the lab and to study very in detailed manner this relationship between all these arteries. And sometimes we can have also an hippocampal artery here coming from the MCA trunk. And this is the lenticulostriate. And once again, the relationship between the lenticulostriate coming from the medial part and superior part of the M1, and entering at the level of the anterior perforated substance to vascularize the deep nuclei here. And once again, my advice is anatomy, anatomy, anatomy for all the young that are attending this meeting. And this is my take-home message. Sometimes we can have a variation, and we have to know very well this kind of variation. We have some proximal MCA variation. This variation, the most frequent one, are the duplication of the MCA and the accessory MCA. What's the difference? When we talk about the duplication of the MCA, we have another MCA branch coming just after the ICA terminus here. So it courses parallel usually to the M1 segment of the MCA. Sometimes you can have an accessory MCA that is a pre-bifurcation, pre-ICA terminus bifurcation point. It can come from sometimes most proximal part of A1, or sometimes even ACA complex area. As we see here, we have a classification type 3 Obner accessory MCA. It's not so infrequent, sometimes 0.1, 0.2%, but we have to know this variation when we take a look to the digital subtraction angiography before to start our surgery, for example, for MCA aneurysm. But we can have also fenestration that is a predisposition factor for aneurysm. And we can also have some twig-like that is not so infrequent here. This is not an AVM. This is just these ontogenetic disorders of M1, and sometimes we can have this twig-like appearance. And as I told you, this is a correlation between clinical classical point. These three digital subtraction angiography are digital subtraction angiography that I collect in my department. This is type 1. And type 1 here, we did an accessory MCA coming from the ICA here. That we can have an accessory MCA coming from also A2 or lateral aspect of the A1, as I told you. And we have to know this variation. We have also duplication, fenestration, twig-like, as I told you. This is the practical reason why we have to know this variation. Another important aspect is this critical point, especially in aneurysm surgery, but also in AVM surgery, is to know very well. These slides require no presentation. This is from Professor Iașag's book. This is the M1 branching pattern, the lateral group variation. We have three main arteries here that I colored in red. These arteries are the uncal artery, the temporopolar artery, the anterior temporal artery. Sometimes we can have variation because uncal artery can arise from the ICA and the polar and anterior temporal artery can arise from the M1. Sometimes all these three arteries can arise from the lateral part of the M1. Sometimes they can be fused in a single common trunk, and I have a slide and a picture that I'm going to show you very soon, where I found the intraoperative a common M1 trunk, starting from which I had the taking off of the polar temporal artery and anterior temporal artery, as we see here, and we have lots of variation, and we have to know very well. We have also an M1 branching pattern. We have a medial lateral striate group variation. Here we can see the classical appearance in the third part of this slide, the third drawing of this slide. This is a classical imagine that we have in mind about lenticulostriate artery, the lateral group of the lenticulostriate artery. But this is not true at 100% of cases. Why? Because sometimes we can have a common trunk here that is added to some taking off of the MCA here. Like in this case, we see this simple MCA aneurysm here, M1, and we can see the starting point of a common trunk along with other 2 or 3 lenticulostriate, and this is the intraoperative picture. And especially in this ICG picture, I can see a common trunk starting from the medial part of the M1. So it means that it cannot be the anterior temporal artery or common trunk starting from the lateral group. This is a common trunk starting from the medial side of the M1 and along with this medial side of the M1. So this is, we have some 2 or 3 additional lenticulostriate arteries. So it means that this branch is critical, and if I endanger and I jeopardize this branch, I can have serious problem with this patient. And this is, for example, another anterior temporal. We have 2 trunks coming from the lateral part of the M1, and we have to easily recognize, if we know the anatomy, that the first one is the anterior temporal artery and the second one is a common trunk of the uncal artery or temporopolar artery here, going toward and directed toward the temporal pole. And here we have another common trunk starting from which we have a bifurcation point in uncal artery and anterior temporal artery here, and we have to know very well in mind this anatomy. Sometimes we can have a variation in terms of bifurcation point, and in terms of bifurcation point, we can know this variation. Why? Because we can have, as I told you, on the left side of this picture, we can have a classical branching pattern here. We can have a early branching pattern or ultra early branching pattern with very short M1 segment. And now this is not common branching point. And to know this, we have to take a look to the coronal slide, to the coronal digital subtraction angiography, in what they call the angiographic Sylvian point, where this angiographic Sylvian point corresponds to the point when the M2 and M3 of the MCA interconnects here at the level, they reflex at the level of the frontoparietal operculum here, and according to this line, we can have the, the variation of the branching pattern. Professor Ārsaghi always said there's a trifurcation or quadrifurcation of the MCA doesn't exist. Usually they are pseudo-trifurcation or pseudo-quadrifurcation. Why? Because the bifurcation is the only one, and sometimes we can face with some early branches coming from the frontal or temporal branch of the MCA, and we have to know very well this in the anatomy. This is a case that I had very recently in my career, and this is not easy to recognize where the bifurcation is, and where the bifurcation is, we don't know if bifurcation is at the level of A and B, because we can be sometimes disoriented. But if we know the anatomy, we know very well that the bifurcation is always at the level of the so-called omega. Because why? Because at the very early beginning, we have a divergent course of the MCA, and then the MCA branch, the frontal and temporal trunk, joined together at the level of usually at the level of very close to the inferior limiting sulcus of the insula. So it means that this is a pseudo-trifurcation, and what we see here is an early branch coming from the frontal branch. We are always, obviously of the right side, frontal branch of the MCA, as I told you. Okay, I don't want to take too much time to talk about the skull base and the reference point, but we have to know very well when we plan our Transilvian approach that we have to know very well also the topography of the pterional region. Here, pterion is not an anatomical, it's not a point, it's a region here where we know very well that we have frontal, parietal, temporal, and sphenoidal part that fuse together here. And we have to know the relationship of the pterion, and we have very, very close and very, very useful landmark here. This is a courtesy of Professor Sebastião Guzmão, one of my best friends in Brazil, that gave me this beautiful picture showing us the relationship between the pterional region and the lateral part of the Sylvian fissure and whatever you want. Here, also during surgery, my advice for my residents and for young surgeons, do your job in a more clearest way. Why? Because sutures are the best landmarks for navigation, and always when I perform my pterional approach, I try to do my best to recognize the difference between and the clear boundary between the frontal, parietal, temporal, and sphenoidal part of the Sylvian fissure. And here we have the, you know, that the relationship between especially sphenozygomatic suture, and the most apical part of the sphenozygomatic suture that correspond to the point where I start to do my pterional keyhole or burr here, and I want to start to open the Sylvian fissure here, there. Why? Because I know that there I have the anterior Sylvian point, I have the triangular part of the frontal opercle, and this is the point where I should start to open the Sylvian fissure. Again, for especially young colleagues here, we have the difference between the before and after the drilling of the sphenoid wing. This is a critical part of every kind of pterional approach. Why? Because this is the key between the this is the key difference between a classic and simple frontotemporal approach and pterional approach. On the left side, we see the frontotemporal approach before drilling the sphenoid part of the sphenoid wing here, and after drilling of the sphenoid wing, everything changed here, and this is the, practically speaking, opening the door to the Sylvian fissure here. So this is a critical part. Don't be shy to remove as much bone as you can in this area according to the lesion that you have to treat. We have some corridors here, Transilvian, subfrontal, pretemporal, and half corridors, and all of these corridors are related to the Transilvian approach and Transilvian perspective to access the skull base, and we can tailor these corridors and our craniotomy and approach according to the lesion that we have to treat. And this is an intraoperative view of the different corridors, but I don't want to take too much time here. We have some variation in terms of pterional approach. We have some extension, and we have some reductive or addictive variation. And this is an overview of the different variation in terms of exposure of, and all of these approaches come from pterional approach. Pterional Transilvian approach is the key for every skull base approach. It is the reference point for every skull base approaches, and all these approaches come from here. And as I told you, this is an intraoperative picture. We see very well where the orbital part, triangular part here is, and the opercular part of the frontal operculum is, and this is the point where I should start the Sylvian fissure here. It depends. In this time, I was dealing with I want to open the horizontal part of the Sylvian fissure, so I went directly to this part, and I should be confident in recognize the ICA, the third cranial nerve lateral to it, and everything. And also sometimes, according to my need, I can open this in the distal to proximal part, the Sylvian fissure. And this is the point where I started to open the Sylvian fissure, for example, when I want to deal with the unruptured MCA aneurysm or other kind of lesion. And also another critical point is the magnification. I can use different kind of technique and magnification to start to open the Sylvian fissure here. And all of these techniques are, you can achieve the mastery in opening all these techniques going to the lab. And the last part of my lecture, just 2 minutes more, just to talk about the third target of the Transilvian approach. It is the most anterior and medial part of the medial-basal temporal region. Why I have to go Transilvian in most of these cases? Because I want to avoid this. When I go subtemporal, I stretch the labbe vein, as you see here, and I risk to damage the labbe vein. And this is another beautiful picture of my friend of Professor Maximilian Nunes, that he showed why we use a skull-based approach. We use skull-based approach to avoid any retraction of the brain here. And as I told you, I want to expose this case, and I want to expose the amygdala and hippocampal formation. I can go transcranial here also to expose the piriform cortex. And this is the transinferior limitic sulcus of the insular via pterional transcranial approach. It is a beautiful approach to approach lesion like this. This is a case that I operated a few years ago. This is a piriform cortex tumor involving the amygdala and anterior part of the temporal, the hippocampal formation here. I went transcranial here because no other way to go transcranial. You see, as close I was to the parahippocampal area here, the most anterior part of the parahippocampal area. This is the post-op view where the tumor was totally removed. Just to mention the fact that for posterior part of the parahippocampal gyrus, I prefer the PST approach that was described by Professor Ture here in semi-sitting position. This is the comparison between the first kind of tumor or lesion affecting the anterior and middle part of the medial-basal temporal region and the posterior part of the medial-basal temporal region, where the most anatomical way is to go through the PST. Obviously, transcranial approach is the approach of choice also for insular glioma, like in this case, and every kind of MCA bifurcation aneurysm, but I don't want to take too much time. This is a case that I recently did, but nothing special here. Is just to show you here how sometimes we don't know the anatomy, we can be disoriented. This is the post-op view of an MCA aneurysm that I recently clipped a few days ago. Here it was very small, but here this is pseudo quadrifurcation. But now if I take a look to intraoperative picture, it was not a pseudo quadrifurcation, it was a common MCA bifurcation with some early branches coming from the frontal temporal branch of the MCA. Nothing special here. I want to stop to talk just to show you that transcranial approach is the approach of choice also for PCOM aneurysm and every kind of lesion dealing here. And I do believe that probably my time is going, and also anterior communicating artery aneurysm. But also sometimes we don't think about very limited role for giant pituitary adenomas, but sometimes transcranial approach can be used also to access this deepest lesion here and skull-based meningiomas and whatever you want. So my take-home message for young guys is to go to the lab and master the anatomy as good as you can, because this is the key for dealing with this kind of lesion. And thank you so much for your kind attention.
Thank you, Professor, for your excellent lecture. The transcranial approach utilizes the Sylvian fissure as an anatomical corridors, revealing a wide range of related areas and exhibiting minimal traction on brain tissue. Under the current conditions, we can further improve it through minimally invasive techniques. Usually, only 2 to 3 centimeters of space is needed to separate the proximal portion of the Sylvian fissure. So the keyhole surgical approach can be achieved. I think it's worth trying and gradually using it leisurely. Thank you.
Yeah. Thank you so much. Yeah, the sense of my lecture was to provide just an overview of what we can do by transcranial approach, but for sure we have to keep in mind the different part of the Sylvian fissure and the Sylvian corridors, because it's a critical point to can tailor your approach. And in most of the cases, as I told you, you open just the sphenoidal part of the Sylvian fissure. You don't need to go more posterior, but in other lesion, for example, insular lesion, superior limiting sulcus, you need to open the posterior part. So you have to master the anatomy of this region to choose and to tailor correctly your approach. And I, hope that this lecture was some helpful for especially young people. Thank you.
Yeah. Is there any comments from our discussants, Professor Yang from China and Professor 𝒂𝒂 from Albania?
Or maybe Dr. Arian? You have some comment?
Hi, hello everyone. It's a pleasure to join you here. It has turned somehow into a tradition that by the end of the year I'm here with you, and it makes for a good luck to start the 225 for me. Dottor Luzzi, congratulazioni per la vostra elezione come il capo del Dipartimento di Sassari.
Grazie, thank you so much.
Sai, un paio di anni fa ho incontrato il professor Crotti, eppure ormai c'è un amico di mio che lavora in Sassari, il dottor Artan Dodda. Non so se lo conosci.
Sì, mio collaboratore. He's very good guy. He's very good guy, good surgeon. Yeah, I love him.
Well, it's a pleasure being here with you today, and I'm blown away by the tour de force of your presentation on the silverfish and its opening. I have nothing left to add, but just I know for the matter of time, you maybe did not have enough time to put some slides. The only thing I would be curious to see next, I will attend your presentation. I look forward to that. Is how the young neurosurgeons can pay attention to make sure that they know where the drainage of the temporal and then frontal lobe stays in your way with your opening Sylvian fissure as you are splitting open your Sylvian fissure. That's the first part. And the second part, there's always been technical notes on opening Sylvian fissure, but very barely few would make notes of the layers, how many layers of Sylvian fissure are. The layers of Sylvian fissure are evolutionary, the landmarks of telling how we can preserve the veins first coming in our way, we open the Sylvian fissure, and then the arteries as we split deeper inside and making our way anteriorly to the circus of Willis. As I said, it was an interesting, very interesting talk, and I could tell that there was not enough time for you to show the passion you had on the anatomy of this very interesting point. So, ti ringrazio dal mio cuore per la vostra presentazione.
Thank you so much. Yeah. The drainage part, I totally agree with you about the venous drainage pattern of the Sylvian fissure. For time reason, I have no time to show everything about the Sylvian. We can talk 3 days about the Sylvian fissure and Sylvian approach. But in 95-97% of cases, we start to open the Sylvian fissure from the frontal side. Why? We want to preserve the Sylvian vein on the temporal side. Why? Because in most of the cases, the Sylvian vein drains toward its remain of the temporal side. But sometimes in 2-3% of the cases, we can have a huge trollard vein that is an anastomotic vein in between the Sylvian vein, superior sagittal sinus, and when we have this very highly connection and this dominance at the dominance into the frontal lobe, the main drainage part, we can start to open the Sylvian fissure on the temporal side. It is very rare. It happened probably 1 time, twice to me in my experience to start to open the Sylvian fissure on the temporal side, but it is not totally to be excluded, especially when we want to go, for example, for amygdala hippocampeectomy and we target to the piriform cortex. Sometimes it can be advantageous. Thank you.
May I please ask you a technical question? I took note of your slides, and you mentioned that some of those slides you have been shared from colleagues in Brazil.
Yeah.
Brazil is a school of thought, and they have an elaborate work in cadaveric imaging.
Not only in Brazil. I visited so many labs. So Brazil.
Tell me about that experience in Italy, if you can, just briefly. How is that?
Yeah, now it's going better. Italy was the place where probably the anatomical dissection was born. One of the most important, place in Europe where the anatomy we had a very long tradition. But after that, we have some bureaucratical and government limitation because the laws about the anatomical dissection were very old. But now everything is changing, and we are going good. Now we are going better than before. And now we have 3 or 4 labs, to the best of my knowledge, and unfortunately, 2 or 3 of these labs are private lab, but we have also public lab and Institute of Anatomy. And my promise when I just started here, my new experience in Sardinia was to, I promised to myself to do any effort to establish a public lab where everybody could come. And but now it's still early for me, and I hope that in the next meeting I can invite all of you in our lab here. And my advice is to work very closely to the anatomy professor and anatomical department, because they are very good in because they know very well the laws and how to establish a lab there, and this is the critical point for every young neurosurgeon.
Thank you.
Thank you,
Dr.
Arion.
Luzzi.
I will bring Arion. I will bring your greetings to Doda tomorrow morning. Okay, to Artan.
Mi hai fatto sentire speciale, ti ringrazio.
Yeah. Thank you.
And Professor Yang want to also want to comment. Yeah.
Hi,
Yeah.
Professor.
Okay, please.
Yeah, please.
Okay, I have seen your wonderful speech.
Thank you.
A lot of message. Of message transfer to young neurosurgeons.
It was just for young.
Very basic ideas and the concept of anatomy is very exciting. To go over the license with you is our honor. And
thank you.
For the practice, it's my honor. Okay. For the practice of neurosurgery operation, maybe some questions I want to ask you. And for the time limits, I only one questions. If we dealing with ruptured MCA aneurysm, with ruptured aneurysm, there may be a swallow of the brain. And what's your preferred start point for dissecting the silver approach from the surface or from the bottom of the SCA?
I follow the rules. And the basic rule is according to which for ruptured MCA aneurysm, my advice is to go from proximal to distal, never to go from distal to proximal, because the critical part of surgery is to achieve as soon as I can the proximal control. And I can achieve immediately the proximal control when I will start from proximal to distal, okay? If we deal with, a ruptured aneurysm, so it's better probably to start the opening of the Sylvian fissure, because it's just a little bit more anatomical from distal to proximal for early exposure on the MCA bifurcation there. This is my advice. This is what I do every day. I don't know if you agree with me, but I never started to open the Sylvian fissure from distal to proximal for ruptured aneurysm. Regardless from the size of the aneurysm and the angio architecture, no, I like to achieve, because it's less stressful for me to achieve immediately the proximal control of MCA aneurysm. And this is the basic rule. This is what we learn from basic, neurovascular surgery from Professor Yashagi. Thank you.
Yeah. Yes, I agree with you. That's I with your ideas that we are the same. Thank you.
We don't need any heroes to open, tailor it. Okay, for ruptured aneurysm, swelling brain, angry brain, don't need to be hero, just tailor it. It's not the way for minimal invasive distal to proximal 1 centimeter opening of the Sylvian fissure. Probably you can do that. We can collect 200 MCA aneurysms, but I don't have that kind of high level of experience, so I feel more comfortable to open the Sylvian fissure starting from proximal to distal and to achieve as soon as I can my proximal control. Thank you.
Okay, thank you.
Yes, thank you. Thank you again.
I also comment. So, thank you for your great lectures, and I would like to learn more from you and give you maybe invite you for webinars to share about your anatomy. It's very useful.
Always available. My pleasure. Thank you very much to all of you. You are very kind to me. Thank you.
I think for the young neurosurgeons, it's important for them to how to palpate for the landmarks. So, for example, like when we do the miniature reorno, where I do it, I always palpate where is the sphenoid ridge, where is the frontal, where is the temple, and then And then by palpation, you already know the anatomy before you make any skin incision. I think that's important.
Yeah.
And thank you so much.
Totally agree with you. Thank you.
Yes, thank you again. Next speaker is Dr. Ahmadinova from Kazakhstan. His topic is hybrid approaches in the management of giant and complex intracranial aneurysms. Case Shirless, welcome.
Absolutely. Thank you for your amazing presentation for young neurosurgeons like me. Dear Professor Kato, dear professors, chairmen, colleagues, I would like to express my heartfelt gratitude for the opportunity to speak at the ACNS Joint Women in Neurosurgery and Young Neurosurgeons webinar. It's truly a privilege for me as a young neurosurgeon. Today I'm excited to present a case series from our department, Department of Vascular and Functional Neurosurgery from National Center for Neurosurgery, Astana, Kazakhstan. And in our department, we do both microsurgery and endovascular cases. And these cases highlights our experience with hybrid approaches in treating giant and complex intracranial aneurysms. As many of you are aware, managing giant and complex aneurysms remains one of the most formidable challenges in vascular neurosurgery. And those cases demand a tailored approach, blending techniques from microsurgery and vascular interventions, and some innovates in combination of both. Each case has its own challenges, but also shows how combining techniques can improve patient outcomes. Labeling an aneurysm as complex implicitly means increased risk of worse outcome in terms of natural history and therapy, and increased need for therapeutic skill and expertise for its treatment. Features commonly recognized as in association with complex aneurysms are its size, large size, giant size, location of difficult or morbid access, configuration, broad neck, branches arising from aneurysm itself, parent artery, part of the aneurysm itself, wall structure like blister-like dissecting aneurysms, calcification of aneurysm wall, intraluminal thrombosis, absence of collateral circulation, and of course, previously treatment. Historically, managing these aneurysms has involved a variety of endovascular and microsurgical techniques. Those include coiling with balloon stents, stent with coiling, flow diversion, or clip reconstruction and bypass with proximal distal occlusion, trapping, and others. Challenges in management of complex aneurysms associated with complications with endovascular coiling or stenting, difficulty preserving parent artery flow, risk of ischemia due to occlusion of vital branches, challenging in flow dynamics, risk of embolism. Endovascular, in such cases, alternative therapeutic modalities like cerebral revascularization with parent artery occlusion present a feasible strategy, achieving flow reversal in the aneurysm while preserving blood flow to the distal vascular territories. At our institution, we routinely perform STA-MCA protective and high-flow bypasses using radial graft followed by endovascular parent artery occlusion in the proximal, internal carotid artery, and MCA. Here are some cases of protective double bypass with parent artery occlusion cases performed at our institution. First case is a 60-year-old right-handed man was admitted to the hospital with a history of headaches and dizziness that had persisted for 10 months. Upon administration, neurologic examination didn't reveal any neurologic deficits. MRI revealed a giant aneurysm. On DCA, you can see the fusiform aneurysm dilatation with thrombosed aneurysm extending from M1 to M2 segment of the right MCA. Given the unsuitability of endovascular embolization or microsurgical clipping, we decide to perform double bypass plus parent artery occlusion. Here you can see our performed double 𝑆TA-𝑀CA barrel bypass, and we confirmed bypass patency with a balloon occlusion test. After confirming the patency of the double bypass, endovascular coil occlusion of the distal and proximal part of the aneurysm of MCA was performed. Neurological examination after surgery didn't reveal any neurological deficit. Patient discharged in well condition, and you can see that aneurysm is totally embolized. Next case is a 70-year-old child with a history of subarachnoid hemorrhage and intracerebral hematoma. This case was previously partially embolized in another hospital. And in the 3D reconstruction of the aneurysm reveals the two M2 branches from the originating from the MCA, directly from the aneurysm dome. To restore blood supply, we performed a double 𝑆TA-𝑀CA bypass, and then we performed coil occlusion of the aneurysm. And you can see the patient experiences temporary left side hemiparesis, which regressed by the third day, and patient was just discharged in a well condition. Next case is a 74-year-old right-handed male was presented with a 3 months history of strabismus and loss of the vision in his left eye. Brain MRI revealed giant aneurysm of 𝑰𝒂. DCA, you can see the aneurysm, and we couldn't see the aneurysm neck. So our treatment strategy was a double 𝑆TA-𝑀CA bypass, which patency was confirmed by balloon occlusion test. And then after confirming, we performed parent artery occlusion with coils. And you can see the DCA immediately after surgery. Aneurysm is totally embolized, and this is a follow-up at 3 months. You can see the aneurysm shrinkage and good patency of the bypass. Next case is a 64-year-old right-hand female with a history of subarachnoid hemorrhage. You can see the partially thrombosed giant 𝑰𝒂 aneurysm. In this case, we also perform a double 𝑆TA-𝑀CA bypass, followed by parent artery occlusion. Next cases with a protective 𝑆TA-𝑀CA bypass and parent artery occlusion cases. Here, a 36-year-old right-handed female with a progressive visual impairment in her left eye. And you can see a giant aneurysm of the 𝑰𝒂. Due to the presence of anterior communicating artery, we decide to perform only one 𝑆TA-𝑀CA bypass. You can see the DCA immediately after surgery, after coil occlusion of the aneurysm. And here is the follow-up after 3 years, visual improvements and aneurysm shrinkage. Next case is a 58-year-old right-handed male, progressive visual impairment in her left eye, with a giant aneurysm of the 𝑰𝒂. We also performed 𝑆TA-𝑀CA bypass, followed by coil embolization and flow diversion. On MRI after 1 year, we can see the shrinkage of the aneurysm. However, on 3D reconstruction, we see that protective bypass doesn't work. I guess it doesn't need. Next case is a 62 years old right-hand female with a homonym 𝒖𝒚𝒂𝒏𝒂𝒓 in both eyes and with giant aneurysm of the 𝑰𝒂. We also performed protective 𝑆T-MCA bypass with a parent artery occlusion. Here is a follow-up at 6 months, visual field improvement and aneurysm shrinkage. Our next case is a protective 𝑆T-MCA plus high flow bypass and parent artery occlusion case. 66-year-old right-handed female with a giant left 𝑰𝒂 aneurysm with a progressive visual impairment in her left eye. And there was no collateral from ICOM and PECOM. So we performed first protective 𝑆T-MCA bypass, then high flow bypass with radial artery graft. Then we performed parent artery occlusion. But after 3 months follow-up, we see that 𝑆T-MCA high flow bypasses are work, but we see the retrograde recanalization of the aneurysm. So we decide to perform coil embolization, this recanalized part from radial artery graft, from the high flow radial artery graft. Here is the catheterization of the aneurysm recanalized part. And here is our results. Aneurysm is embolized totally from the radial artery graft. Here are some cases, extracranial aneurysms managed by 𝑆T-MCA bypass and parent artery occlusion. 50-year-old right-hand female with a palpable swelling on right lateral region of the neck, a giant right cervical 𝑰𝒂 aneurysm. This case wasn't suitable for endovascular treatment due to post-aneurysmal stenosis. You can see on 3D reconstruction. So we performed protective 𝑆T-MCA bypass followed by a parent artery occlusion. Here you can see the patency of the 𝑆T-MCA bypass. And here's the follow-up at 3rd month. You can see the aneurysm shrinkage and good patency of the bypass. And finally, I want to share with you some cases of 𝑆T-MCA bypass for failed endovascular treatment cases. Here's a 49-year-old right-hand male with a progressive visual impairment in her left eye with a giant aneurysm of the left 𝑰𝒂. First, we treated by coil and flow diversion. Here you can see DCE immediately after surgery, after coil and stent embolization. But after 20 hours, patient experienced left side hemiparesis. On DCA, we see instant thrombosis, and that's why we performed emergency 𝑆T-MCA bypass. Here is a follow-up. On the 2nd day, hemiparesis was regressed. Here is a follow-up on 2nd and 3rd year, aneurysm shrinkage and MCA territorial blood restoration through the MCA 𝑆TA bypass. And last case, 35-year-old right-hand female with a giant aneurysm of the left 𝑰𝒂. She was previously treated with stent and coiling in another hospital, but patient experienced progressive visual impairment in her both eyes with bitemporal hemianopsy after endovascular treatment due to dense coiling and compression of the optic chiasm optic nerves with coils. So in this case, we first performed common carotid artery mobilization, temporary occlusion of the left eye, then we performed protective STA, MCA bypass, and aneurysm trapping. After we aneurysm debulking, coil extraction, and decompression of the optic chiasm. You can see here extracted coils from the aneurysm. It's DCA immediately after surgery, and MCA territory restoration through STA MCA bypass, good patency of this bypass, and visual impairments. Here is the control MRI after 3 months. Visual field impairment and bitemporal hemianopsy were resolved after surgery. So primary goal of the surgical treatment for giant complex aneurysms is the permanent occlusion of the aneurysm from the circulation with the preservation of the blood flow in vascular territories and relieve the mass effect. Endovascular reconstructive procedures such as flow diverters, placement of microsurgical clipping are not always usually available option for this aneurysm. And in these cases, reconstructive techniques such as aneurysm trapping and deconstructive techniques such as proximal and distal occlusion with bypass revascularization are possibly safer, especially in patients who lack sufficient collateral circulation. And in conclusion, I would say that even in the era of flow diverters, bypass techniques has very important in the aneurysm management, and combined approaches of endovascular and microsurgery techniques, some complex aneurysms can minimize surgery associated and can help achieve good outcomes. Thank you for your attention. This is our team, our Department of Vascular Neurosurgery, from National Center of Neurosurgery, Astana, Kazakhstan. Thank you.
Okay, so thank you very much, Dr. Mammadinova. Due to the time constraints, we can only have one comment or question for each lecture. Any question or comments?
Yes, Professor. Here are some questions from Tianjin. Okay. Thank you, Eoda. Thank you for presentation for very exciting cases of pyroclinic, very huge aneurysm.
Thank you.
This is a very special place for open surgery and endovascular treatment. To my acknowledgement, for recent 10 years, most of pyroclinic aneurysm was treated by fluid diverters because even very small one. But most of your case is very suitable for bypass. I think most cases, even treat with fluid diverter will be very difficult. Maybe the result is unpredictable, and so we see that those cases with bypass surgery. So I have one question to you. That is, in your cases, some was with STA, MC bypass, or double bypass, and some of them with high flow bypass. What's the difference for these two methods? That's my question. Thank you.
Thank you for your question. Before decision to do double bypass or one STA MCA bypass or high flow bypass, we first check the collateral cerebral circulation, presence of anterior communicating, posterior communicating arteries, and also in some cases we performed temporary balloon occlusion test to check correct the neurological deficit, then we decide to do double STA or one or high flow bypass.
And for more detail, when you perform high flow bypass, what's the transplantation artery vessels you use? The radial artery or the subference vein?
We use radial artery graft.
Okay.
Yeah.
Okay.
I have a comment, not a question. Can I?
Yeah.
Yes.
Okay, thank you.
Only one.
First of all, I want to congratulate Dr. Iroda Mamadinova for this wonderful and shocking presentation about how many cases they treat. I know very well some of the guys from Kazakhstan, Dr. Saparov and Dr. Nurgildi. I don't know if you know them. They take the main field of interest, especially brain surgery, but you are doing a great job there. You are doing a great job. So the cases, especially for young people that are connected, the cases that Iroda showed us are the proof that bypass surgery and neurovascular surgery is alive. Is alive. We need neurovascular surgeons. Why? Because everything is on the right side of his last slide about the algorithm and management of giant aneurysms, are the aneurysms that are most suitable for surgery, especially bypass surgery, so flow replacement surgery, but not only bypass surgery, also clip reconstruction in most of the cases. And you have to hold some techniques that you commonly don't use in your routinely practice, like, aneurysmectomy, aneurysmography, and everything. That's a special fragmentation, stacking and sicking. All these techniques are special techniques that we use for giant aneurysms. And from Isuya studies, but not only Isuya studies, you know very well that more than 50% of the giant aneurysms will bleed, okay? And the remaining 25% will go toward embolization. That is a catastrophic event for the patient. And third aspect, even with flow diverter, sometimes we don't perform, every day in our clinical practice, postoperative MRI DVI, okay? If we perform DVI, we will see how many patients will suffer from embolization, okay? Embolization from especially giant aneurysm. So that's the reason why we still need neurovascular surgeon. We still need neurovascular surgery in our future. And that's the reason why for young neurosurgery, we should be prepared for this, okay? This is my personal humble point of view. So it's neurovascular surgery is alive. It's still alive. It's more than alive. Thank you so much.
Yeah.
Okay, thank you. Next speaker is Professor Gleb Danilov from Moscow, Russia. His topic is Introduction to the ACNS AI subcommittee. Welcome.
Dear colleagues. Oh, thank you. So, dear Professor Kata, dear Professor Quinlan, esteemed hosts, moderators, discussants, speakers, and colleagues, it's an honor for me to speak today and to introduce ACNS subcommittee on artificial intelligence, a remarkable initiative kindly proposed by Professor Yoko Kata. And thank you so much, Professor Kata, and all the colleagues for recognizing the importance of AI in neurosurgery and for the decision to establish a dedicated subcommittee. I want to share my vision and some thoughts on why this subcommittee is important and the mission and roles it can fulfill. AI technologies are rapidly evolving in their diversity, and ChatGPT, for example, is an AI tool that can assist you in various ways, for instance, to improve your scientific writing in English. And here I asked ChatGPT to compose a poem about AI in neurosurgery, and I hope you will find it inspiring and enjoyable. This is an example of generative text processing AI. And computer vision is another branch of artificial intelligence. Here is an example from our recent study where we evaluated the accuracy of using computer vision by to detect neurosurgeons' proper posture and hand positioning, as well as analyzing motion metrics during microsurgery. So we use the term AI to encompass a wide range of diverse technologies. But first, let's in brief clarify what artificial intelligence actually is in its essence. We often imagine it as an intelligent robot that thinks and behaves like human being. However, that's not entirely accurate. It's true that in a strict sense, in a narrow sense, AI is a mathematical solution which automates intellectual tasks normally performed by humans. However, human intellectual activities are incredibly diverse, and this automation, essentially the imitation of human actions, can be accomplished through various technical methods. Therefore, AI is not a single robot, but a broad collection of diverse technologies. These include computer vision, image recognition, natural language processing, speech-to-text conversion, language translation, voice synthesis, risk assessment, and more. As you can see, human intellectual activities are varied, and so are the technologies that replicate them. I believe it's crucial not to humanize artificial intelligence. That is why, in my opinion, AI technologies is a more accurate term than AI, as it better captures the wide range of tools and methods it comprises. And of course, a hallmark of contemporary AI technologies is their capability to learn from data, lots of data. This process is known as machine learning. Today, machine learning is a cornerstone technology of AI, and you have probably heard the term deep learning, which is found inside the machine learning area as a subtype of machine learning. It's crucial to note that artificial intelligence intersects with another expansive field, data science, which focuses on extracting valuable insights for science and practice from data. Neurosurgery generates lots of data. We often struggle to fully benefit from neurosurgical data. Moreover, all the crossroads of these fields lies at the crossroads of these fields lies mathematical statistics, the foundation of modern medical research. Ultimately, all this knowledge and technology serve the field of decision making, so enabling the best choices for patient care. This is precisely what neurosurgery demands practically, selecting the most effective solutions, using them all and using all available technologies, whatever we call them. Neurosurgery stands out as the only clinical discipline that provides direct access to the living human brain for clinical research. Artificial intelligence combined with data science technologies holds the potential to uncover valuable insights about how the human brain functions and malfunctions, all derived from data. I believe the most powerful driving force behind the development of artificial intelligence today is young neurosurgeons with a passion for innovation. AI offers a fertile ground for research, providing equal opportunities for all men and women, beginners and experienced professionals alike. However, I feel that young neurosurgeons and the ones who will actively embrace and apply these technologies in practice in the years to come. Therefore, it's crucial to discuss AI, its significance, and actually engage young neurosurgeons in research today. This is why it has been proposed to define the mission of subcommittee as promoting awareness of AI applications in neurosurgery and fostering research in this field. AI technologies are growing in popularity, yet their use in medicine remains limited. So research in this area is labor-intensive, and identifying appropriate task for effective AI application presents its own challenges. It's essential to educate neurosurgeons on the fundamentals of and potential of AI, while also highlighting successful examples of research and implementation in neurosurgery. In my view, AI subcommittee's primary focus should be organizing educational and scientific events centered on the following areas. I suggest categorizing the key aspects of AI in neurosurgery based on two principles. The first one is technological principle, And according to that principle, the topics will be neuroimaging analysis, AI for analyzing intraoperative images from microscopes, endoscopes, exoscopes, text data analysis in neurosurgery, which is a vast field, augmented reality and neuronavigation, 3D modeling and additive manufacturing technologies, neurophysiological data analysis, and robotics. And based on the second principles as subspecialty, I would suggest the following topics: AI applications in neuro-oncology, in functional neurosurgery, in vascular neurosurgery, in spinal neurosurgery, in neurotraumatology. I propose hosting online events on the topics outlined above with a frequency of once every 2 months to allow sufficient time for preparation. These events can alternate between educational lectures and research, or even combine both. Each event could include 2 or 3 presentations lasting 15 to 20 minutes each, following by a 15 to 20 minutes discussion for a total duration of 1 or 2 hours. At the end of each year, the subcommittee members could compile a digest of AI technologies in neurosurgery or literature review or report summarizing the state of advancements in the field, potentially for publication, maybe in ACNS. Regarding committee members, although AI technologies are widely popular, their research in neurosurgery still remains limited, and there is a limited number of experts in the field. So I suggest gradually inviting lecturers with relevant research experience to our events, and eventually including the most accomplished researchers and speakers as members. Currently, there are 3 members proposed by Professor Yoko Kata and Professor Ben Chakfong. If you kindly accept it, these are Dr. Alessandro Boaro from Verona, Italy, Dr. Jake Bai from Tianjin, China, and Gleb Danilov from Moscow, Russia. And if you have any suggestions for potential colleagues to include, I would greatly appreciate your input. So if you agree with this general concept, I propose scheduling the first event for mid or late February 2025. Over the next weeks, we can discuss the program. As I conclude my report, I would like to revisit the concept of artificial intelligence. It's important to recognize that the sum of these technologies doesn't equate to an artificial human. After all, a person is more than intellect. There is will, emotion, empathy, compassion, conscience, etc., etc. It's all about technologies. So I believe the best contribution of AI subcommittee can make for neurosurgeons, especially young ones, is to help them stay informed about AI technologies, get involved in AI research, and think critically about these tools. With at least a basic understanding, they can develop realistic expectations and set appropriate goals for AI research and its applications. Thank you so much for your attention.
Yes, thank you very much, Professor Danilov. Professor Danilov introduced us the most popular AI technologies. This aspect deserves our more attention.
Thank you, Danilov. Professor Lan, can I make a short comments about this committee?
Yeah, please.
Yes, and I think it's a very good idea to start about this committee. I think many of us, the young neurosurgeons, and are very interested in the AI. And personally, I really appreciate Professor Kato who share about this idea and have you to initiate this committee. And I'm also interested in to gathering the young neurosurgeon like the one next to me, and very interested and do have a personal skills in AI. And I think with that, this platform will set up not only about the educational, but it will be very international research collaboration platform. Because talking about AI, I think is one of the main use is the research, but also the second use is about to the promotion and of neurosurgical knowledge to the general public or the neurosurgeons. And I think I would like to thank you so much, and also thank you, Professor Kato, to have this vision to set up the AI subcommittee. And I hope in case you have any need, for example, I could also invite some of the, or suggest some of members if you agree, but it will be under your charge. Yeah.
So, Dr. Ben, thank you very much for your recommendation. So can I talk the guy who is sitting beside you? You recommend it now.
Yes. Can you introduce yourself?
Let me introduce Dr. Wu.
No, I want to talk with him.
Okay, please.
Yeah.
Hello, Professor Kato. My name is Zhuolin Wu. I'm a PhD student for my God teacher, Professor Yang.
So what do you want to do in future regarding the AI?
I'd be good at computer science, such like Python and RStudio and another software.
Excellent. So, Dr. Yang?
Yeah.
Any recommendation about?
Yes, I say that, and the AI and the ChatGPT is the new computer science. We are neurosurgeons, so we depended on the young generations to do more works on the computer times. And I think right now, AI the technology of AI is mimic the people. I don't think in recent time computer and robot can replace neurosurgeons, but in the future time,
yes, I think so. Yes, I totally agree with you. So we will lose our job, I think, very near future. Dr. Danilo, maybe can you talk with the young guy from Tianjin?
Yeah, thank you so much for such a nice proposal. Thank you so much, Professor Kato, once again, for establishing such a committee and the value that you expect from such an activity. That is the way that a young guy introduced himself is something close to my pathway, because I also do programming on my own in Python and R. That's why I'm leading the Laboratory of Biomedical Informatics and Artificial Intelligence at my home institution. So I do believe when you understand the technology and you know the application in the professional domain such as neurosurgery, you can combine this knowledge to be a kind of interpreter. You can explain doctors what these technologies are about, and you can translate into technical tasks for specialists who can program and solve find the solution in the technical field. So this interdisciplinary approach is very important, in my opinion, to find the most appropriate solutions for artificial intelligence in neurosurgery. And I'm really enthusiastic and optimistic on that type of joint research, and I hope my colleagues will also support this initiative. Thank you so much.
Thanks so much.
Okay, thank you very much. Next speaker is Professor 𝒂𝒏𝒕 from Japan. His topic is functional posthumous rhizotomy for treatment of 𝑭𝒐𝒊𝒏𝒕. Welcome.
Okay, thank you very much. Let me show my slides. Okay, I'm going to talk about functional posterior rhizotomy. This is people often say this is selective posterior rhizotomy or selective dorsal rhizotomy, but I use the functional. The reason I tell you why, the reason I tell you later. Okay, so the functional posterior rhizotomy. What is the functional posterior rhizotomy? The answer is the functional posterior rhizotomy is a neurosurgical procedure to reduce spasticity by cutting spinal posterior root at the root level based on the neurophysiological criteria. And actually, this is a 6-year-old boy, and this is before surgery. In this case, the patient ranked at level 3, and I had overall average 37%, and this is 6 months later after the surgery. His motor function improved remarkably by reducing spasticity. This is what we can do by functional posterior rhizotomy. And the goal or the purpose of the surgery is different from the preoperative degree of the ability of the motor function. So today, I don't have enough time, so I'm somehow focused on the first function posterior rhizotomy. Now I told you, and surgical indications and goals, and surgical procedure, and interpreted new physiology during rhizotomy, and decision-making, surgical outcome, and the multidisciplinary team approach. I'm going to talk about these issues. So surgical indication. This is a surgery for the children with spastic para or quadriplegic paralysis. The age from 13 months, 2 years and a half to adolescent, and delivery for less than 10 years old. Because as children get aged, the more and more contraction of the joint develops. So the surgical effect is not obvious at that case. So the younger, the better. But less than 2.5 years, the children is still developing in the neurodeveloping, and you don't know what the influence of spasticity in the children. So the youngest children are operated 3 years old, and oldest 21 years old. And family support, this is most important for post-op continuous rehabilitation possible. And the family understanding for realistic goal of treatment. The children with severely disabled children are unable to walk, and the family must understand those limitations of the surgery. And no association with the serious atherosclerotic involuntary movement. Like this case, dystonia atherosclerosis, sometimes after surgery with the reduction of spasticity, this involuntary movement can worsen because there is no spasticity, no limitation of the movement. And so the functional posterior rhizotomy is a surgery to reduce spasticity. It is applied for the harmful spasticity. You should understand harmful spasticity caused by the CNS damage, especially for those children with cerebral palsy. The spasticity of other origin can also be treated by functional posterior rhizotomy, but you need some care and some experience for the spasticity of other origins. So, like this case, you need a deliberate, careful judgment required for the indication of surgery. The cerebral palsy with severe atherosclerosis or dystonia, I usually don't operate in the patient with atherosclerosis. Association with severe joint contraction, you can't see the effect of surgery. So the orthopedic surgery comes first, like this case. The motor function utilizing spasticity. This is often observed in the older children. They sometimes use the spasticity to support their body. So with that spasticity, the motor function worsened in this case. Unilaterally predominant spasticity, you can, and I operate several cases, and but you need to be very careful about the indication. And if this caused by hemispheric region, but still spasticity exists, you can apply. But somehow the cutting rate of the left and right is different. And the family acceptance is not positive or rather negative. This is not a surgery to persuade the family to do this or something. You have to do this surgery or something like that. The family must understand the limitation and the goal of the surgery. So this is my personal series of the patient, about more than 250, and cerebral palsy. Most of the cases are cerebral palsy, but 18 cases, the post-encephalitis or degenerative disease or something else included like this. And the number of surgery is somehow different. With the introduction of intrathecal baclofen, the number of surgery decreased, and later on, still now it's going up. And the age distribution like this, 4 years is the most common, but age pension like this. So the goal of the treatment, or like able to walk, this means the GMFCS level 1 or 2. The goal is the improved stability and locomotive function. And this mild case, GMFCS level 3, the goal is the improved locomotive function. And difficult to move, total care case, GMFCS level 4 and 5. These patients, the goal of the surgery is the pain and agony release of the patient and less burden for caregiver. This is this difference of the goal of the surgery. You have to understand. And the preoperative evaluations, the motor function, spasticity, ROM, and ADL, and electrical evaluation also needed. Sorry, this is written in Japanese, but like this preoperative evaluation sheet we use. And MRI is also helpful to decide how the influence of the CNS damage to the spasticity. And also CT scan, you have to know the anatomy of the spine, the shape, or the level of the corners and the caudal equine. Yeah. And this is a GMFCS, the level of the motor function of the preoperative children, like this. And you know, the level 1 children, this is a motor function, GMFM, gross motor function. Usually, come to the best score at 6 years old. Level 2, same. Level 3, 5 to 6 years. And level 4, 5 becomes younger because of the severity of the disability. So this is a case if the patient was not operated and the spasticity remained. So the surgery, there's several procedures, and the Peacock introduced this surgery as the caudal equine, and Park moved back to the surgery as the conus medullaris, conus level. And I use this Peacock standard procedure and also modified limited procedure. This is a cutting operating only the lower lumbar and upper sacral level and indicated for the GMFCS level 1 to 3 children. And in like this case, the spasticity usually predominantly located at the ankle joint. This is very important. So in this procedure, precise localization of the root enables detailed intraoperative neurophysical evaluation. This is the most important point. And the reason why I don't like this part is very limited, narrow space, and precise neurophysical evaluation is often difficult in this case. So this is a surgical position, and I usually work with PT, physiological therapist, for touching the muscle clones. This supports the limitation of the EMG monitoring. This is an explanation of the L1, L3 subpyral dissection. This is very important for subpyral dissection. So you don't see any so many bleeding from the surrounding tissue. And in this case, the lamina is turned to the rostral side. And laminotomy, I use also plus laminotomy. So here is the cutting line, and this post-op CT scan shows the lamina at the original position. And here, this is the exposure of the nerve root. And this is the filum terminus, and this is the left side of the caudal equine, and this is the left side. And like this, S2, S1, L4, L4, S3. This is a limited, this is a limited procedure, so only L3 to S2 were exposed. And like this, the rootlet below S3 are too small, so I don't dissect. And usually, I include the testing for L5 to L2, L4, L5, S1, S2. And in limited procedure, L4, L5, and S1, S2. So arachnoid membrane is dissected as the root exit zone like this. And this is a dissection of the S2 root from S3. And this is also the extension from this one. And here, that's the posterior root from the anterior root. This is the root, L5 root, and you dissect the L5 root from the anterior ventral root, motor root, and the sensory posterior root like this. And then you place the seat and deliver the electrical stimulation. And sometimes there's like this bridging route. This is another reason why I prefer this procedure, not the corpus medullaris, but the caudal equina. You can understand these anatomical variation, and you can treat them, including this one or this one. And after dissecting the posterior root, you can divide the posterior root into 3 to 6 rootlet like this. This is a rootlet 1, rootlet A like this, and deliver the electrical stimulation to the each rootlet. And the rootlet dissected and the electrical stimulation delivered. And if I judge it is highly abnormal, then it is cut. And the rootlet, which is not so abnormal, is preserved. So this is before rhizotomy after opening the dura, and this is after rhizotomy and dural closure, and osteoplastic laminoplasty like this. So this procedure is able to apply like this a very serious scoliosis patient. And okay, Professor Park, she passed away a few months ago. He introduced this post-rhizotomy at the conus level. And sometimes people say this is Park's procedure, but actually the original procedure by Fasano, who ignited the posterior rhizotomy in 1970s, used this conus approach. This is the revival of the Fasano's procedure. But anyway, he operated at the conus level like this. And I use this procedure like in this case. But what I found is it's very difficult to understand the spinal level of the root. You can apply electrical stimulation, motor stimulation, but it's still not clear which one is which, especially if it comes to S2, S3. You can't differentiate which one is the S1, which one is the S2. So I don't use this procedure now. And my understanding of what people say selective rhizotomy, and what I said, this is a functional rhizotomy. And selective rhizotomy, people usually often cut each root decided 40 to 6%. In mild case, 40%, severe case, 60%, like this. But in this functional rhizotomy, you can individually decide each root how much you can cut, you need to cut. So more individualized procedure is possible. So regarding the interrupted neurophysiology, what I usually do is baseline the BCR, bulb cavernous reflex, and the F wave, and interrupt and BCR and Flender mapping and nerve root simulation, and confirm the reduction of the spasticity by using F wave. And after closure, BCR to confirm the binary function and F-wave to confirm the reduction of spasticity. But most important and basic procedure, what you need is a potential mapping and nav root or routed simulation. This is the two basic neurophysiological procedure. And this is a potential mapping to preserve the neurological function. In this case, like S2 has the highest amplitude, so you can't cut the S2. You can cut up to down to S1, like this case. And this after potential mapping, and then I start a routed simulation. I use a 10 Hz. People usually use a 50 Hz. 50 Hz, it's sometimes difficult to differentiate the artifact from the muscle contraction. So I prefer to use the 10 Hz 1 second simulation. The decision making to cut or not to cut, it's not straightforward, but the one criteria is a segmental low extremity muscle innervation. If the muscle response out of this spinal segmental innervation, then we can judge it abnormal. Like this attitude, L2, L3, and L4 sometimes included. So if you use the simulate L2 dorsal root and so you had a response from the S1 innervated muscle like hamstring or gastroc, then you can judge it's abnormal. In the same way, if you simulate S1 and you can get the response from adductor or quadriceps, then you can judge it's abnormal. Another criteria is using the tetanic simulation and age reflex study of the amplitude recovery. But here, in normal children, there is a suppression for the tetanic simulation. But cerebral palsy patients, this suppression is very weak here. So in this range, the cerebral palsy patient or this response, the second response, the amplitude suppressed by the tetanic stimulation. So like this case, this is a localization of the root rate. And here, this is a simulation of the L5 root. You can see the response from the left adductor. And here, the response amplitude is not suppressed, even increased. So this gives the reason to judge this root is abnormal. So I can further divide the root into rootlets and do the same procedure and decide the rootlet is, if I decide this rootlet is abnormal, then I cut it. This is a very severe L5 GMFCS level 5 patient with scoliosis. And here, all the muscle response from the 0.4 milliampere simulation. And even you can see the contralateral response from the left hamstring and left gastroc. So this rootlet was judged highly abnormal. There is one, this criteria, Phillips and Park. This is very famous. And this is somehow I modified and used. And actually, to cut or not to cut, you have to think the role of interpreted neurophysiology, as I told you now, and this is important. And also, distribution of degree of spasticity. This is also important. And the age, motor function, and the degree of mental retardation. So if the children's mental retardation is very severe, the post-operative rehabilitation is not easy. So at that time, somehow restrict the cutting rate. And usually, depending on the preoperative severity of the motor function, I cut about 15 to 20 minimum and maximum 80% of the to be examined. Okay, and in general, the abnormal root or rootlet often comes to the lower level L4-5S1, especially in the GMFCS L1 or L2. The more abnormal root is observed in L4, L5, S1. So this is like this. Then somehow the abnormality comes more severe in the lower level of the lump sacrum. So I have a kind of double standard, double criteria. And if you look at this, I decided to choose like this minor, mild case of spasticity. I will concentrate on the cutting at L4, L5, S1 level. This is the reason why I introduced limited procedure for rhizotomy. Yep. So like this, the functional rhizotomy. This is a level 1 patient, and the preoperative gross motor function level is 78. 100 is full score, 78. I chose limited procedure. I didn't include L2, L3 from the beginning. I just made L4, L5, S1 laminotomy and cutting these 3 root. And the average to compare with the other case, including L2, L3. The average cutting rate is 22%. This is L3, level 3, GMFCS level 3. In this case, I got 49%. This L5 very severely disabled, severe spastic patient, I got 71%. And the motor function, post of 1 year, this increased to 19. This increased to 50 to 50%. This from the beginning, 0 and 0, no change. So you remember, this is a general performance of selective dorsal rhizotomy. And this is what I call the functional posterior rhizotomy. More individualized cutting is possible in this procedure. So this is a surgical outcome in my early case. And this spasticity reduced and GMFCS keep improving. And what I found from this, this is a GMFM score. This is a GMFM score means the motor function. 100 is best. So if the motor function is better, you don't need to cut less. If the motor function is very severely disabled, you have to cut more. This is very reasonable. And this line, this means this y equals something like this. So simplify like this. This is y equal 100 minus very simplified formula. So somehow you use this, you can estimate how much you need to cut preoperatively using the GMFM score. So cutting rate is 100 minus GMFM 88 score. This patient, GMFM is 28. The actual cutting rate is 67%, but the preoperative estimation is 72. So approximately is a very close cutting rate. So people often say less invasive. This is very important. But less invasive doesn't mean the small wound. For functional neurosurgery, the less invasive means less rootless cutting based on the individual neurophysiological background. This is my understanding of what I would like to tell you. So this is a post-operative condition of the children motor function. Like this, most of the patients improve. If you look at the data of using the GMFM gross motor function 88, this is the level 1. The initial reduction is caused by reduction of the spasticity. Children don't need to adjust the reduction of the spasticity. So at the first month, usually the GM wave drops, but soon it recovered within 2 to 3 months, and then later on slowly improved like this. And the GM level 5, this is a very severely disabled children. The motor function doesn't change. And the goal of the surgery like this patient, not the improvement of motor function, the release of the pain, agony, and the lessen the caregiver's burden. And if you look at this data, remember this, most of the children with cerebral children palsy, the motor function doesn't improve after 6 years old. So the impact of functional posterior is very important, like this case. And even like this, subluxation of the hip joint improves after surgery. So the role of each treatment for spasticity, we have to think about. There's, we can differentiate the role of each treatment by diffuse indication to the diffuse hypertension and focal hypertension, and the effect of the permanent effect or reversible treatment. And the functional posterior rhizotomy comes here. The intrathecal baclofen comes here. And the botulinum toxin comes here. And orthopedic surgery comes here. You have to understand this difference of each treatment for spasticity. And my understanding and what I think is the first step we have to do is the reduction of spasticity for using functional posterior rhizotomy, baclofen or Botox, and then as a second stage, orthopedic surgery. And the new rehabilitation follows during the treatment period. So the formation of a reasonable treatment system, what is important is not the selection of treatment, but the combination of treatment. You can somehow combine functional posterior rhizotomy, and then the residual spasticity you can treat using Botox. And the comprehensive spastic clinic is important to decide which treatment you choose and how you manage the spasticity. And the neurosurgery and orthopedic surgery are not competitive, but collaboratory in the treatment of spasticity. So my message today is the goal of functional rhizotomy is to accomplish maximum reduction of spasticity with minimum cutting of the posterior root or rootlet. And individualized tailor-made root or rootlet cutting is required for functional rhizotomy. Application of the detailed interpreted neurophysiology enables functional selection of the root or rootlet to be cut. From this viewpoint, it's not selective but functional surgery. And children with GMFCS level 1, 2, and a part of level 3, whose fascia predominantly located at the ankle joint, can be operated by the limited procedure. And interpretive neurophysiology plays a critical role for functional rhizotomy as well as safe rhizotomy. Application of the detailed interpretive neurophysiology enables to accomplish maximum reduction of spasticity with minimum cutting of the posterior root or rootlet. Thank you very much for your attention. So it's not selective surgery, but it's functional surgery. Thank you.
Thank you. Thank you very much for your excellent lecture. Any question or comment?
Yeah, this is somehow a different kind of presentation today. Yeah, talking about more hot discussion about vascular surgery or AI or something. But this is functional surgery for very important for pediatrics.
Can I tell something just as a comment, not a question? I couldn't ask anything about your presentation because you're super detailed. But anyway, it's just once again for young people, this is another level of neurosurgery. Okay, this is another level. This is ultra micro neurosurgery from my side. So It's the reason why your presentation was excellent, and we are going exactly toward that direction. In a very close future, we will be able to, spare any. It's the fiber surgery, it's not a gross total surgery. It's fiber surgery, so it's excellent. Congratulations for your beautiful job. Beautiful. Thank you.
I didn't talk much about the because of the time limitation, but the cerebral palsy is always born about 0.2% of all birth baby. Even at country like Italy or Japan, or even the country in developing countries, the percentage is same. That means the 2 children among 1,000 births becomes cerebral palsy.
Yeah.
So we have to treat this spasticity more. Nearly 60% of the cerebral palsy is spastic cerebral palsy. So we can have so many children, but still it's not treated appropriately. And now what I'm feeling is neurosurgeons in Asia, even in Asia, are more and more interested in this procedure. So I'm going to work more hard to disseminate this procedure in future.
I was impressed of your video. You have beautiful result. It works very well. It works very well. It's a different concept of neurosurgery, microneurosurgery. Thank you.
Yes, Professor Hugo, congratulations for your so exciting presentation for us. I think today some of us are vascular neurosurgeons. We don't know function very, very well. But when I was a young neurosurgeon, when I learned from professors, they told me that function neurosurgery is the neurosurgery of neurosurgeries. Today I say that. Congratulations. Thank you very much.
Thank you.
Okay, thank you.
Can I have questions?
Yes, please. Go ahead.
Thank you, Professor Morita, for the presentation. I have 2 questions. The first question regarding the complication of the procedures, especially the incontinence after surgery. I know that you got the IONM as the priority to select the rootless to cut, but I'm still worried about the complication with the sphincter function. And the second question is, this procedure seems to be like maybe only applicable for lower limb spasticity. And what about the upper limb spasticity? Maybe because of the anatomical reasons, but do you think that is there any way that we can apply the same principle for upper extremity?
Okay.
Thank you.
Very interesting, a very important question. Okay, about incontinence, I use the pudendal mapping, and I haven't experienced real incontinence after surgery. This is so important to perform pudendal mapping. Pudendal mapping is a must procedure for this surgery. And however, 2 patients worsened urination. The reason, why? Both 2 patients had a very severe spasticity, GMFCS level 5. They use spasticity for voiding. You understand? Spasticity shrink the bowel, then they can discharge urine. After surgery, spasticity of the bowel also reduced, so they were unable to urinize after surgery, and they need catheterization after surgery. So this is some very controversial issue, but if you use pudendal mapping appropriately, you don't need to worry about the postoperative urinary dysfunction. This is very important. Another issue, this is also very important, about limb hospital. The difference of the leg and the hand. Hand motor function more deliberate, more skillful compared with the leg motor function. Leg motor function somehow gross. Hand motor function more fine. You need to do so many movements. And also, sensory is very important here. And there are several papers about the cervical dorsal rhizotomy, but it's never became so popular in the history of rhizotomy because of the complication of the limitation of the procedure. Probably, if you want to reduce the flaccid of upper limb, you can use more peripheral procedure or orthopedic procedure. However, the one thing you have to remind, I didn't show you today, nearly half or more than half of the patient improves hand motor function after rhizotomy of the lumbar cycle level. You know, there is some primitive reflex circuit from the in the central nervous system, and if the spasticity of the lower extremity reduced, some such kind of primitive reflex circuit is reduced, and motor function of the hand improved, or the respiratory function also improves. So the children becomes more skillful after surgery, or and less vulnerable for the pneumonia or something. It's very interesting, and we call it remote effect. The doctors who perform rhizotomy all understand it, but it's unpredictable. So I don't say such kind of remote effect property to the family or parents. I don't say it. But if I was asked, I tell you. But the percentage is 60% and unpredictable.
Yeah.
Okay?
Yeah, I see. Thank you, Professor.
Okay, thank you again, Professor Morata. At last, let's thank a lot to the four speakers for bringing us very good topics and beautiful techniques. We are looking forward to contacting more in the future. Now, let me return the procedure to the host, Dr. Ben.
Thank you so much. And I think it is a really great day to see so many brilliant minds and brilliant actors together. And I really wish that under the vision of Professor Yoko Kato, and we will go bigger and achieve more and bring neurosurgeons around the world all together to achieve a higher standard of neurosurgery. And any final comments from Professor Yoko Kato? Please unmute yourself.
So yes, thanks so much. So the four speakers is very high level talk, especially Sabino. Maybe your knowledge of the anatomy is very, very, I think, supportive the clinical cases. I think.
Thank you, Professor.
So maybe
Thank you very much.
In future, please support the ACNS educational activity more, please. Thanks so much.
Sure, Professor. I'm totally available, as I told you. It's my commitment. Thank you.
So thank you so. And also the Miss Iroda. Yes. Thank you very much for the very difficult cases, I think. So the indication and the surgical skill and the techniques, many things is very high level, I think. Thank you very much. You should continue accumulate the cases more in the future, and please publish the paper. And Danilo, please always great kind of IT man, I think. I think that he will have the nice committee member. And today we involve one more, the guy from China. Thank you very much for Dr. Yan and Ben. Recommendation of him. Already it has fixed already. So now he is one of the member of AI committee. And finally, the Morta Sensei, thank you very much for your very special field. But we need, as a neurosurgeon, I think we should know what is the best and what is the recent treatment for such cases. So we learned a lot, more than 2 hours. Thank you so much.
Yeah, thank you, Sharon. So much for coming.
Yeah, I know. Sorry for coming late. I think it was a very good webinar today. I learned a lot. Especially, I just want to say what Professor Kato said. Yeah, let's continue this. Yeah, Ben, we keep our thing going on.
Yeah.
Okay. Good night, everyone.
Thank
Okay.
you, Sharon.
Bye-bye.
Goodbye.
Goodbye.
Bye.